So this is Helen Baxter. She works for the ME group, and she's going to talk today about how can dietitians and the wider MDT support people with ME and CFS. So I think this is a really interesting subject that you're going to share with us today.
Firstly, I'd like to thank the Malnutrition Task Force and particularly Leslie for organising this learning event and inviting me to speak today. My name is Helen Baxter and I'm an advocacy worker specialising in health and social care at 25% ME Group. We're a national charity which supports people with severe and very severe ME, and I have a particular interest in malnutrition and tube feeding. So, myalgic encephalomyelitis, or chronic fatigue syndrome, is defined by NICE as a complex, chronic, fluctuating condition affecting multiple body systems. So, it affects approximately 250,000 people in the UK, and it has many similarities with long COVID. It ranges from mild, where people are probably still able to work but have had to give up all leisure or extracurricular activities, down to very severe. An estimated 25% have severe or very severe ME/CFS and are housebound or bedbound, and some of the most severely affected will require tube feeding. Quality of life with people with ME/CFS is lower than in many other chronic disabling conditions. But very little demographic data has been collected on ME/CFS, so it's not really known how many of these patients are older. However, as many patients typically develop ME/CFS as teenagers or young adults, and there isn't a cure, many patients have been ill for decades, and some have been severely affected from childhood right through to older age. For those ME/CFS patients who are older, comorbidities associated with old age, such as heart disease, further contribute to the disease burden. So the cardinal symptom which distinguishes ME/CFS from other conditions is post-exertional malaise, and that's the worsening of symptoms associated with minimal amounts of activity, and this can be physical, cognitive, or emotional energy expenditure, and of course it impacts nutrition and hydration. In the more severe cases, even chewing triggers post-exertional malaise. ME/CFS can cause diet and nutritional problems that would benefit from dietetic input, and also at times from the wider MDT. Gastrointestinal symptoms are common across all disease severities, and one study found that 85% of ME/CFS and 65% of their long COVID participants had gastrointestinal problems. There are a number of reasons why people with ME/CFS may have difficulty accessing even basic nutrition, let alone good nutrition. Nutritional intake is often suboptimal. They may have practical issues accessing food, they may not be able to go to the shops, and in the case of the older population, they may not feel confident or have the resources to do an online shop. And they may have difficulty preparing that food. If you break down meal preparation into components, there are a lot of components, and for someone with an energy-limiting illness, meal preparation can be very difficult, and for those with severe ME, it's actually impossible. They may be unable to hold the plate or the cutlery. They may have difficulty chewing and swallowing, and that can be due to muscle weakness, poor coordination, lack of stamina, or sensory changes. And people also report changes in the taste and smell of food, and or hypersensitivity to taste, smell, and texture of food. Food intolerances are also commonly reported. Probably the most common ones are to gluten and lactose. And people with ME/CFS also report intolerances to the additives and preservatives in ready meals. The gastrointestinal symptoms such as sore throat, pain on eating, abdominal pain, fullness, bloating, constipation, nausea and vomiting may prevent patients from ingesting sufficient food and drink. And disturbed sleep patterns are also common in ME/CFS, including sleep reversal, daytime hypersomniance, and of course they are common in the older population, and they may make it difficult to follow a conventional healthy eating pattern in relation to foods eaten, meal composition, and meal times, particularly where the person is reliant on carers. But I think it's important to keep in your mind that if we're talking about problems accessing appropriate food, we're actually also talking about hydration, and that's just as important. And there may be reasons why people with ME, particularly older people, might not have enough fluids. For example, they may have problems with incontinence, or due to fatigue or poor mobility, they may want to limit their number of trips they make to the loo. There are also comorbidities associated with ME/CFS that can further compromise nutritional intake. They include irritable bowel syndrome, mast cell activation disorder, postural tachycardia syndrome, fibromyalgia, and also gastroparesis. And we know that the first line advice for the management of POTS is to drink 2 to 2.5 litres of fluid a day, increase the salt intake, and have small, frequent meals. And when we're talking about older people, there may be additional illnesses that may directly or indirectly impact on nutrition and hydration, or medication which impacts on when they can actually eat. So, what can dietitians and the wider MDT do to help these patients? Dietitians can aid a patient with ME/CFS to optimize their diet whilst minimizing energy demands and gastrointestinal symptoms. The British Dietetic Association has produced a resource on diet and ME/CFS. This may include further assessments of sensitivities and intolerances. Histamine intolerance should be considered. NICE recommends working with the person and their family or carers to find ways of minimizing complications caused by gastrointestinal problems, such as nausea, changes to appetite, swallowing difficulties, sore throat, or difficulties with buying, preparing, and eating food. They can explore with the patients and the patient's family or carers, if applicable, how posture, eating, and drinking aids, and foods that are easy to chew and swallow, so soft texture, use of sauces, pureed food, etc., and nourishing milky drinks, be they homemade or commercial, can support food and fluid intake. The person not getting adequate nutrition and fluids can be a huge source of worry for the carer. Dietitians can play an important role in supporting those carers, both family caregivers, so the unpaid carer, and also home care workers. If possible, arrange times of appointments when the main carer is going to be there to advise on any provision of food that might be best managed and tolerated. And the occupational therapist can support with any adaptations which makes things easier. So it might be easy to use tin openers, perching stools, or adapted plates and cutlery. The OT can also provide assistance with drinking, with aids again, and it may be necessary to refer to adult social care, as a package of care may be needed to support with nutrition. And this is a case study. This is a man in his 80s. He has moderate ME, so under the NICE guidance, he's restricted in all activities of daily living. He went and saw his GP because he was getting gastrointestinal problems, particularly nausea and bloating, and he has some weight loss. The GP is referred on to the dietitian. When he was seen by the dietitian, he explained he was having 6 small meals a day, 4 of those were hot meals, and that his wife was cooking or microwaving them. He thought the preservatives in the ready meals might have been exacerbating his gastrointestinal problems. And actually, we hear that a lot. People with ME/CFS report intolerances to additives and preservatives in the ready meals. He's taken his wife with him, and they mentioned to the dietitian that because of his ME and old age in his wife's case, they were actually struggling to do the shopping. He also said he was having difficulty using cutlery and food kept dropping on the floor, and he was too fatigued to clean it up, so his wife had to do it. The dietitian gave advice on nutritional meals and food fortification, as well as on the management of the gastrointestinal symptoms. So the dietitian then referred on to the OT. She saw them at home and she provided some adapted cutlery. She also observed his wife struggling in the kitchen and her arthritis in her hands, so she gave her a perching stool and some gadgets to help. His wife also mentioned that she was having to assist with personal care, and it was obvious she was experiencing carer strain. The OT then did a referral to adult social care for a community care assessment for the gentleman and a carer's assessment for his wife. And adult social care gave him a daily care call for personal care and assistance with meal preparation. And that carer also helped them to do their online weekly shop. His wife was given some hours when she could go out, and a carer would sit with him while she went out because she was struggling to get out because of providing those ready meals. So it just goes to show, when we're talking about elderly people, the disease burden can be greater because they have multiple chronic conditions. Given the high instance of gastrointestinal problems, food intolerances, comorbidities, difficulty shopping and cooking, and not being able to maintain a healthy weight or an unintended weight loss is very common. And as I've said, many patients with ME/CFS report an intolerance to the additives and preservatives in ready meals, which due to their limited function, they may be forced to rely on. People with severe ME/CFS may need their food cutting up or to be fed, and that's often just because of sheer debility. NICE Guidelines 2021 recommends referring people with ME/CFS who are at risk of malnutrition, losing weight, or following restrictive diet for a dietetic assessment by a dietitian with a specialist interest in ME. And it's really important to use the malnutrition screening tool to monitor these patients, including in the community, so that you ensure a weight history is available to all healthcare professionals involved in their care. And as with frail elderly patients, it can be more difficult to screen very severely affected ME/CFS patients for malnutrition, as they're bedbound and they can't stand to be weighed. And in the case of the ME/CFS patients, they can't tolerate the sensory stimuli of being weighed, even by hoist. In these instances, it's necessary to take a different approach to assess nutritional risk. So look for visual evidence of weight loss, for example, clothes being looser. Find out what the person's dietetic intake has been over the last 3 to 6 months, and whether they've experienced problems such as dysphagia. A mid-upper arm circumference measurement gives the clinician an estimated BMI category. In patients struggling to maintain a healthy BMI, food fortification can help, and also prescribing oral nutritional supplements. However, some patients find they don't tolerate nutritional supplements well, and in some cases they actually exacerbate the gastrointestinal symptoms. Often they'll need to be started at a subtherapeutic dose, and you may have to try various different brands before you find one that suits. Because people with severe or very severe ME/CFS are housebound or bedbound, they're at risk of vitamin D deficiency and osteoporosis. But because of the symptom exacerbation associated with the hospital visit, a DEXA scan is often impossible to arrange. Some people with very severe ME/CFS, even with all the necessary support in place, just can't meet their nutrition and hydration needs. Often it's just due to sheer debility, but it can also be due to dysphagia. Early intervention tube feeding has been shown to be beneficial in ME/CFS patients. Unfortunately, we've found a number of cases that the patient has been allowed to develop life-threatening malnutrition before there has been appropriate intervention. The patients and their families had raised multiple concerns at a primary care level, and yet either they hadn't got the necessary support in primary care or the interventions hadn't been available, hadn't been enough. So we published a series of case reports where malnutrition was allowed to become life-threatening. All the patients in the paper were admitted to hospital. The malnutrition pathway hadn't been appropriately followed, and their BMIs on admission ranged from 11.4 to 14.7. Yet despite this, there wasn't appropriate initiation of tube feeding when they got to hospital. Common themes emerged. For example, all the participants were allowed to become and remain extremely malnourished. All participants were thought to have anorexia nervosa, and psychiatrists became involved. And that happened before the tube feeding started. The inability to swallow was also deemed to be a psychological manifestation. In each case, the doctors resorted to making inappropriate psychological diagnoses without positive evidence of psychopathology, and they failed to recognize the significance of the malnutrition. And this raises the question of how aware are we, or our healthcare professionals, that ME/CFS can lead to serious problems meeting nutritional needs. It's stated in the NICE guidance on ME that patients with very severe ME/CFS might need tube feeding. And of course, in this instance, NICE Clinical Guideline 32 is relevant. And this is a case study from the paper. This was an adult with very severe ME. She's been diagnosed with severe ME as a child. She made some improvement and then deteriorated again. In her mid-30s, she was in a nursing home and started having difficulty swallowing. So the speech and language therapist did diagnose dysphagia. She was seen by the community dietitian who prescribed oral nutritional supplements, but she wasn't able to tolerate these, so she became very malnourished. But the primary care team just didn't recognize the severity of the situation, so she had 7 weeks where she really struggled to eat and drink. As the situation deteriorated, she was told if she didn't go into hospital, she would be sectioned under the Mental Health Act, so she reluctantly agreed to a voluntary admission. She then had 2 weeks in hospital, where she was intermittently given intravenous fluids but no nutrition. During this time, she was screened using the malnutrition screening tool, and she had a score of 4, so a high risk of malnutrition. She deteriorated to the point that she needed an intensive care bed, and a nasogastric tube was sited. But she was so malnourished that she actually needed metabolic stabilization. She also felt that she was being treated as though she had an eating disorder. Despite being reliant on the feeding tube, when she was discharged, she was told it wouldn't be recited. It had to be recited a number of times as an emergency in A&E. And 4 years later, the clinicians actually did decide to give her a peg feeding tube, which is usually given in cases where longer-term tube feeding is needed. That, and being given a tube feeding dietitian in the community improved things for her, and she's now back at a healthy weight. We also find that people with ME/CFS can present late to dietetic services. They may also have experienced stigma from health and social care professionals due to the lack of knowledge about ME/CFS and the outdated belief that it is psychosomatic. So it's really important to validate their symptoms. Always listen to the patients, as they know and understand their condition better than most healthcare professionals. In terms of providing the appropriate dietetic support in both primary and secondary care, it may be necessary to provide reasonable adjustments. Patients with mild to moderate ME/CFS may be able to attend clinic, but the physical and cognitive exertion of doing so is likely to exacerbate their ME/CFS by triggering post-exertional malaise. Those with severe and very severe ME/CFS will not be able to attend clinic. Following on from the pandemic, we've seen a greater number of NHS services who will do appointments by telephone or video, but there are times when it's just necessary to do that domiciliary visit. So examples of the necessary reasonable adjustments will be providing a low sensory environment for the person to rest in if they've come to outpatients, providing information in a variety of accessible formats depending on the person's preference, so written, audio, or electronic, and giving them extra time for processing that information because of those cognitive difficulties. We know some clinicians may have little or no experience of working with people with severe ME. In this case, NICE has a really useful phrase, and that's risk assess each interaction with a person with severe or very severe ME/CFS in advance to ensure its benefits will outweigh the risks. For example, worsening their symptoms to the person. For people with very severe ME/CFS, think about discussing this with the person's family or carer on their behalf. So it's important to think how you can minimize the exertion on the person whilst keeping the focus on them. So where possible, utilize what the carer knows, use them to gather information where applicable, and of course only with the person's consent. I think we're probably most used to doing this in elderly medicine. And as I've said, listen as the patient knows and understands their condition better than most healthcare professionals. And you may find during a consultation that the family member or carer appears to be speaking for the patient, and that's usually just to conserve their energy. We hear ME/CFS patients, particularly those with severe ME, are very concerned that their needs won't be met. For example, because of the need for a low sensory environment, a side room's needed. And in response to requests, 4 ME charities have actually created a hospital booklet, and it has spaces to put in information relevant to that person and information to give to clinicians, including a section on nutrition, and that is on the Malnutrition Task Force website. So there is a huge unmet need for dietetic support for patients with ME/CFS, and this can be challenging, particularly at the severe end of the disease spectrum. But by taking a person-centered approach and making the necessary adjustments, dietitians and the wider MDT can make a valuable input to the life of someone with ME/CFS. Thank you.
Thank you very much. And we'll have it on the website soon, and people will be able to listen to it after. And I'm sure that people will maybe email you if they've got any questions that they want to talk to you about.
Yes, that's absolutely fine. Please do email
Lovely.
me.
Thank you very much indeed.